Assalamu alaikum. Good evening. It's my pleasure to chair this meeting on the cardio, renal, and metabolic disease in diabetes. The meeting is organized by the Gulf Association of Endocrinology and Diabetes and is sponsored by Bayer Pharma. My name is Bashar Effendi, and I'm an endocrine consultant at Tawam Hospital and STMC. And I will be joined by three expert endocrinologists from Qatar, Professor Tariq Al-Hed, Professor Mohammed Bashir, and Professor Riaz Malik. We will review together the magnitude of CRM syndrome in patients with type 2 diabetes and discuss the rationale for the benefits of the selective mineralocorticoid receptor antagonism. And we will end up with the clinical implications. This activity is actually accredited by Dubai Health Authority, 2 CMEs hours. Please, if you have any questions, place them in the Q&A question box, and we will get and address that after the end. Again, this is supported by buyers. Now, I just want to remind you, if you like to become a member to GAID, which has many privileges, I like you to scan this and to join us to, take the advantages of all these privileges. Please scan this code if you like. Now I will start by presenting our first speaker, my dear friend, Professor Tariq Al-Hed, and he will be reviewing the magnitude of the CRM in patients with type 2 diabetes. And Dr. Tariq Al-Hed is well known to the audience. He's a senior consultant endocrinologist at HMC in Qatar, and he is the president-elect for the GAID. And again, he will discuss the magnitude of CRM disorders in people with type 2 diabetes. Professor Tariq, the floor is yours, please.
Thank you very much, Bashar. Thank you very much, Bayer. All delegates and respected attendees, welcome to this session as part of the educational ventures proposed by GATE as part of enriching the educational platform. And I would like to thank again Bayer for providing the appropriate logistics for what I'm sure is going to be a very successful evening. I will join my other two distinguished colleagues, Mohammed Bashir and Riyad Malik, and I'm going to set the scene by giving you a sort of a relatively concise and comprehensive presentation on the epidemiology of diabetic nephropathy. Right? Okay. So we all know that, there is a rise tide of end-stage renal disease, and diabetes tend to be a very leading cause for the end-stage renal disease in our adult population. And from the US renal dialysis services, this current cartoon is depicting that diabetes is responsible for over 50% of the adult patients with end-stage renal disease going for dialysis. And the data showed the patient from 1984 going into the year 2010, and depicting both number of patients as well as depicted. And it is the exact such prediction has happened in our current practice. So we know that diabetic nephropathy does start with proteinuria, and mark of diabetic nephropathy, as we know, is proteinuria, and the proteinuria tend to be coupled with relentless decline in the EGFR, and as a sort of a consequence of such actually evolving very drastic medical condition, we do get eventual kidney failure, and many patients actually die due to renal death, due to metabolic decompensation. However, the great majority of patients actually do suffer from cardiovascular disease, and we'll come to that actually, and this is what is all about it actually. This slide is from the International Diabetes Federation 2019 atlas in its 9th edition, and we know that around that time there has been just below 500 million adults with diabetes worldwide, and this represents roughly just below 10% of the global population of the world. And out of these actually patients, actually 416 million of them do actually suffer from type 2 diabetes, which accounts for roughly around 90%. And you might not be surprised to know that chronic kidney disease affects 2 out of each patients with type 2 diabetes, with an estimated value of around 160 million. This is back around half a decade ago, and I'm sure the number has risen significantly. And compared with type 2 alone, comorbid chronic kidney disease does increase cardiovascular mortality as well as morbidity. And we know that type 2 diabetes on its own right actually increase such propensity. And this is from a very actually important paper by Afkarian et al. Published in the American Journal of Society of Nephrology in 2013. And it has nicely shown that, if you don't have neither type 2 diabetes or chronic kidney disease, the fact that your chance of getting a sort of a 10-year cumulative incidence of cardiovascular disease does not exceed actually 3.4%. And if you have type 2 diabetes alone, this will jump to 6.7%. And if you have chronic kidney disease alone, this will actually represent even a higher value of 9.9%. And when you combine actually chronic kidney disease and type 2 diabetes, such actually 10-year cumulative incidence of cardiovascular disease jump to just below 20%. And the presence of diabetes and chronic kidney disease is very bad news, as it does increase the risk of myocardial infarction. And this tend to have a sort of an exponential actually sort of rise whenever you have diabetes with reduced EGFR, and when you have actually all of them, the risk of myocardial infarction tend to be actually very much elevated, as being shown by a study from Alberta in Canada. And the presence of the amalgamation of diabetes, ischemic heart disease, and heart failure is actually 8 times more common in patients with chronic kidney disease versus those without chronic kidney disease. And such risk actually of cardiovascular events in patients with diabetes does actually go as a straight line as our albuminuria progress. And if you could see in the left-hand side slide in this very important paper by Fox et al. Published in the Lancet 2012, that, when you have, sort of early macroalbuminuria of 2.5, milligram, the cardiovascular deaths tend to be actually jumping above the sort of a normal sort of risk. And when the albuminuria does actually progress, there will be increased significant actually cardiovascular mortality. And the albuminuria and decline in the EGFR tends to actually go hand in hand. And when you reach actually, the stage of urine deficit positive proteinuria, such decline in the EGFR tend to be very much apparent. However, back when I was actually in training, the absence of proteinuria used to be used as a denominator for non-diabetic kidney disease. However, this has proven actually not to be the case. It turns out that there are actually two phenotypes of patients with actually diabetic kidney disease. The classical phenotype, as you could see in such excellent paper published in the Lancet Diabetes and Endocrinology actually back in 2015, when the other group of non-proteinuric phenotype actually do show. And the absence of proteinuria actually signify the non-proteinuric phenotype, and this actually tend to decrease renal function without any concomitant proteinuria, which is actually being reported to be present in around 50% of people with type 2 diabetes. And it has been shown that the declining glomerular filtration rate can be recorded before or even without progression to macroalbuminuria. And there is high actually prevalence in women with metabolic syndrome, and the accelerated decline in the eGFR tend to be actually quite actually significant and can be shown as a two different pathways that might or might not converge in the same patient. And there is uncertainty actually of the benefit of the classical angiotensin converting enzyme inhibitors or the ARB in this actual group of patients. So the absence of proteinuria does not rule out actually diabetic kidney disease. Now, the current theory is that the drivers of chronic kidney disease in type 2 diabetes tend to be actually focused in three areas: the hemodynamic theory, the metabolic theory, as well as the inflammation and fibrosis theory. And it's thought actually the three actually sort of denominators or factors tend actually to overlap. And the hemodynamic, factors tend to be associated with elevation of the blood pressure or the intraglomerular actually increase of pressure. The metabolic actually pathway is associated, as we know, with poor glycemic control, and the inflammation actually and fibrosis has been well described by so many actually key findings, and this will result in the tubulointerstitial damage, glomerulosclerosis, mesangial expansion, and glomerular hypertrophy, and eventual kidney fibrosis and progression of kidney disease. And actually, such three factors are very important when we consider treatment. And the target for treatment, could be either focusing on the hemodynamic factors or the metabolic factors or the inflammatory factors. Classically, the drugs that actually act on the hemodynamic factors focus on the ACE and ARBs, the thiazide-like diuretics, the dihydropyridine calcium channel blockers, as well as the SGLT2 inhibitors. The metabolic actually factors, of course, mainly metformin, which has been associated with the main sort of protective effect. However, recently SGLT2 inhibitors, GLP receptor agonists, as well as anti-hyperglycemic agents may all play a role to a varying degree. And of recent, actually, the inflammation and fibrosis has been actually focused on certain drugs, which is the mineralocorticoid receptors. So this will just tell you about the agents I have just told you for the specific drugs that tend to target actually the progression of chronic kidney disease. And the ACE and ARB has been actually well studied. I'm not going to spend time on this, and I will leave it to my other two respected colleagues. I'm sure Mohammed Bashir is going to cover this, and later on Riaz Malik will show you. But various studies actually, including Renal, that looked actually on the effect of the one of the first ARBs, losartan versus placebo. It is very famous study actually being published in the New England Journal of Medicine by Barry Brenner, one of the gurus actually of diabetic nephropathy and others, as well as other ARBs. So I will not go into such details. And despite the classical conventional treatment that includes the ACE inhibitors as well as ARB and the other measures to control adequate blood pressure control. Proteinuria tend to continues, and recently new players actually have come into the scene. Liraglutide and renal outcomes in type 2 diabetes has been actually very well known for the last decade or so, and this has been published actually, back in 2017 in New England Journal of Medicine. Again, I'm not going to go into such details of the drug therapy because it will be the focus of my other two respected colleagues. And yes, I would like to also focus to the fact that, the very recent, actually last year, a very landmark paper by Berkovich et al. Was published in New England Journal of Medicine, and this actually included, for the first time, the weekly GLP receptor agonist semaglutide, which has shown actually to be quite beneficial in these patients, which actually comprise a diversity population with all spectrum of renal disorder, including patients on dialysis or transplantation, as well as, people who have got a very reduced. And this have shown that, the GLP receptor agonist, primarily semaglutide, does have actually effect on the major kidney disease event, as well as the rate of decline in the eGFR, as well as the deaths from cardiovascular causes. So, what next? Where are we going from here? I think the field has been very promising and has been very exciting because despite the ACE, ARBs, GLP receptor agonists, and adequate blood pressure control, proteinuria continues. So now we do have at our disposals new measures, and I will leave actually this to my other respected colleagues. I think I will stop here, and my other colleagues, Dr. Mohammed Bashir, to take the center stage. Thank you very much.
Thank you. Thank you. Excellent presentation. Before I move to our second speaker, Professor Mohammed Bashir, I will remind you to register for our Congress that is coming soon in October, next month actually, 24th and 25th. Please try to register or try to get a sponsor to support you attend this, major local and international Congress that we used to in the last 12 years. So please do your best to attend. Now it's my great pleasure to present our next speaker, Professor Mohammed Bashir, who is a professor at Hamad Medical Corporation, and he's the director of the National Diabetes Center for Women Wellness and Research Center. And Professor Mohammed will be talking about selective mineralocorticoid receptor antagonism in patients with diabetes. So please, Professor Mohammed, the floor is yours.
Thank you so much, Dr. Bashar. And thanks for the organizers and Bayer and the choice. So I'm trying to share my slides. So we're going to look at mineralocorticoid receptor agonists in chronic kidney disease. These are my disclosures. And as you already heard, this talk is sponsored by Bayer, and I have no interest in financial interest in this company. So, Dr. Tariq Al-Had has set the scene about the prevalence and the incidence of diabetic kidney disease, but it's worth looking further about the rise of the magnitude of the problem over the last decade or so, or since the start of this century. This data looks at a large number of patients with type 2 diabetes and chronic kidney disease, and it basically reported that the incidence of new incidence of chronic kidney disease has pretty much increased by about twofold over a period of 15 years, and the prevalence has jumped by about threefold over the same period of time. And there are many reasons for this increase in both the incidence and particularly the prevalence of diabetic kidney disease, which is probably beyond the scope of this talk, but Dr. Tariq touched base with some of them. And you've already heard that the classical stages of diabetic kidney disease starts by a process of hyperfiltration, followed by macroalbuminuria, a decline in EGFR, and then end-stage renal disease. However, what's critical to point out that these forms or these classical stages of diabetic kidney disease are well known and described in type 1 diabetes, but is assumed to happen in type 2 diabetes because we don't know when the disease or when the disease starts in type 2 diabetes. However, what is a critical, and Dr. Tariq has touched base with that, is the pathogenesis of renal disease in people with type 2 diabetes is actually quite complex. And it doesn't only start by diabetes, it's actually started by obesity. And to be accurate, it actually starts with ectopic fat deposition. And the term fatty kidney disease is a term that is going to be, we're going to hear more and more about it, which is describing fat deposition around the kidneys that causes a chronic inflammatory process. And obesity per se is now a cause of, or a recognized cause or association with renal failure. However, the fat infiltration around the kidneys seems to stimulate a chronic inflammatory process. The hyperglycemia that occurs in people with type 2 diabetes is also known to propagate this inflammatory process, leading to chronic inflammation and endothelial dysfunction. And quite often, this results in hypertension that worsen the situation and start to stimulate a process of inflammation within the glomerular cells and leads to glomerular sclerosis. As you heard at the talk previously, that end-stage kidney disease, pretty much regardless of the cause, end up with kidney fibrosis, with a tubular interstitial disease and glomerular sclerosis. So the pathogenesis in type 2 diabetes seems to be complex and seems to start even before diabetes is actually evident. You already heard about the way we diagnose diabetic kidney disease. We use two methods, urine albumin creatinine ratio and the estimated GFR, glomerular filtration rate. What's important to put this in context, as Dr. Tariq already mentioned, that if you look at albumin creatinine ratio in a cross-sectional manner and follow those patients on a long period of time, you will realize or find that data have shown that the higher the albuminuria, the higher are the mortality rate, cardiovascular event, and end-stage renal disease in people with or without diabetes. And albuminuria is just a marker of an endothelial dysfunction. So it indicates that there is a process of atherosclerosis that's been going on for a while. However, if you want to look at the change in albuminuria, looking at it on a longitudinal manner, you will find exactly the same. The higher the progression of albuminuria, the higher are the rates of end-stage renal disease and death. And if the albuminuria regress, as you can see in the graph, there could be a reduction, or there is a reduction in end-stage renal disease. EGFR as well, if you look at it cross-sectionally, you will find that the lower the EGFR, the higher is death, myocardial infarction, and stroke. And if you looked at it in on a longitudinal way, you will find it is associated with the same cardiovascular event. However, it's worth pointing out here to this surrogate marker that's widely used now in clinical trials and reported in most clinical trials looking at kidney disease, which is the EGFR slope. And the EGFR slope is basically the changes in EGFR, annual changes in EGFR. And what's critical about this EGFR slope is that once they start to exceed 3 mils per minute, in other words, the reduction is more than 3 mils per minute, 1 to 3 is considered kind of within the age-appropriate reduction. Once they exceed this limit, then the risks of major renal disease, cardiovascular disease, and death is actually increased. And it is, as I said, a surrogate marker that you're going to see throughout most of the studies reporting in chronic kidney disease. And the correlation between albuminuria and EGFR is very evident. The higher the albuminuria, the higher is the progression of chronic kidney disease, the higher is the decline rate in EGFR, and hence the higher rate of end-stage kidney disease. And the way kidney disease is diagnosed is simply through the KDIGO classification, looking at both albuminuria and the EGFR. We cannot classify the patients without looking at the two factors together. And you can see this is a very well now known heated map where the the more red the color is, the higher is the risk of end-stage renal disease. However, the same graph or theme could actually be seen with chronic kidney disease. The higher the albuminuria, the lower the eGFR, the higher our cardiovascular mortality. And this is being shown in larger studies. So the same heat map can denote chronic kidney disease, end-stage renal disease, cardiovascular death as well. And chronic kidney disease or diabetes kidney disease is managed through a tighter glycemic control, a control of the blood pressure, the use of RACE inhibitors, as you just heard from Dr. Tariq, and the use of statins as well. But most recently, we have the disease-modifying agents, which includes the SGLT2 inhibitors, mineralocorticoid receptor agonist, and antagonist, and GLP-1 receptor agonist. And today, we're going to focus on finerenone, which is a mineralocorticoid receptor antagonist. And the mineralocorticoid receptors are actually widely spread on the cardiac cells. It's also available on the vascular endothelial cells, smooth muscles, on the renal tubular cells, and on macrophages. And activating the mineralocorticoid receptors is actually a friend when we need it. So when there is bleeding, sepsis, hypotension for any reason, the activation of these mineralocorticoid receptors helps in the recovery from this form of insults. However, the chronic activation of these receptors through metabolic disease like obesity or hypertension can become actually a foe and start to cause chronic problems, including cardiac hypertrophy, remodeling, myocardial ischemia, and coronary artery disease. And most critical for this talk is that a widespread vascular fibrosis and stiffness that include also renal fibrosis, leading to end-stage renal disease. And there are three different forms of mineralocorticoid receptors available. The only non-steroidal one is finerenone. The other two, which is well known to all of us, which is spironolactone and eplerenone. And there are some differences between the two. The potency in terms of the receptors, we all know eplerenone is less potent in terms of its binding to the mineralocorticoid receptors and as an antagonist. However, the selectivity differs. We know eplerenone is better, more selective than spironolactone, but finerenone is more higher selective than mineralocorticoid receptors and pretty much has no side effects or sexual adverse events. So the other differences between these agents, because of the selectivity, is that finerenone has very little effect on blood pressure. It does not have sexual side effects, and the impact on hyperkalemia is lower than the other two mineralocorticoid receptors. And it acts through two ways. It acts through binding direct effect on the mineralocorticoid receptors, leading to direct effect on the process of fibrosis and inflammation, but also act through the messenger RNA in controlling gene expression, and also in an indirect way reduces the same process of inflammation and fibrosis. And if you want to take a look at the summary of what we know about the effect of finerenone from animal data and so far from studies, is that finerenone effect on the heart is actually quite positive. It reduces ventricular dysfunction and it improves the overall cardiac remodeling process. When you look at the vascular part, when you look at the coronary artery, it seems to improve the coronary artery flow and the myocardial blood supply and improve cardiac recovery. It seems to reduce pulmonary hypertension. It also seems to have a positive effect on the retina and reduce retinal vascular injury and inflammation. When you look at the kidneys, the effects are also on the reducing inflammatory process, reducing fibrosis, and reduces apoptosis. And an interesting effect of this molecule is actually on its action on the brown adipose tissue, and it seems to activate brown adipose tissue, and that means that they improve metabolism and might have an impact in reducing obesity per se. So the focus is on kidney disease, and the main study that looked at finerenone in diabetic kidney disease is called the Fidelio study. Always reminds me of Italian opera. Fidelio. So anyway, so the Fidelio study looked at patients with chronic kidney disease, but patients have to have diabetes. They have to have an eGFR between 25 to 60. As I told you, the lower the eGFR, the higher the risk of end-stage renal disease and cardiovascular disease. But the patients have to have macroalbuminuria, prostaglandinopathy, or they have a wider range of eGFR, but they have to have macroalbuminuria. Now, the primary outcome was a composite outcome of end-stage renal disease, a 40% reduction in eGFR and renal death, and the secondary outcome was a 4 points MACE that includes cardiovascular death, MI, stroke, and heart failure. And the population, typical person in this study was an average age of 65. Majority were males and were white with a decent HbA1c. Half of them almost have cardiovascular disease. Almost all of them were on RACE inhibitors. And the duration of follow-up was about 2.5 years. And it's always critical to look at these type of graphs because it tells you where most of the population are. And you can see majority of them between moderate to high risk for both renal disease and cardiovascular disease. And another critical point, in my point of view, when you examine these studies, is to have to understand how it gets analyzed in order to avoid misinterpreting the results of these trials. So the results of the trials, the analysis usually happen in a hierarchical way. So the primary endpoint was renal outcome. If this is positive or significant, they move to the next one, which is cardiac outcomes. And if this is significant, they move to the third one, fourth one, and so on and so forth. Once they hit a negative study, they stopped reporting on any p-values, and you cannot interpretate the results of these findings. They only considered exploratory. This is critical because the primary outcome here was actually positive, and there was an 18% reduction in the composite renal outcome in this trial. And there was also a 14% reduction, which is the main secondary outcome of the 4 points MACE reduction. However, the second one, which is death from any cause, was not statistically significant, and hence they stopped monitoring. And what we currently know that these are the effects of finerenone in people with diabetic kidney disease. It reduces the kidney composite renal disease, and it reduces the 4 point MACE. When you take a look at the albuminuria, which I've already, and Dr. Sarg already explained, that the reduction, that albuminuria is a surrogate marker of endothelial dysfunction, and it seems the reduction in albuminuria is actually associated with reduction in end-stage renal disease. What you can see here is that during the first 4 months, there is a decline in albuminuria by about 30-35%, which seems to persist throughout the study, but seems to plateau after that. So it doesn't go any further than that. And this is actually seen in almost all the studies that looked at diabetic kidney disease recently. SGLT2 inhibitors and GLP-1 receptor agonists, you see exactly the same effect that happens early, and then it plateaus thereafter. What is critical as well is to look at the eGFR slope. So there is an initial dip in the eGFR that is seen with finerenone by about 3 mL per minute, but then the rate of decline slows down, and they pretty much meet back in about 24 months. And then later on, the rate of decline in finerenone continues to be lower than the placebo. And as I told you early on, that the eGFR slope is a marker, or is a surrogate marker of chronic kidney disease and cardiovascular mortality. And one way of looking at the cohorts enrolled in the study is to look at what's the placebo eGFR slope was. And it was almost 4 mL per minute. And I said anything above 3 is associated with high rate of death and end-stage renal disease. And that tells us that this cohort is actually a high-risk cohort. And when you look at this graph, you wonder if they have allowed the study to continue a little bit longer to learn more about the effect of finerenone, because as an anti-inflammatory process, it's actually quite plausible that the impact on eGFR will take some time. So how about the effect of potassium? As I told you, it has the rate of hyperkalemia is lower compared to other mineralocorticoid receptors. And what you can see here, that there is on average an increase in the serum potassium by about 0.25 millimoles per liter, which seems to plateau thereafter. and also the impact on blood pressure is critical. Very little, almost negligible effect on blood pressure compared to placebo. How about severe adverse events? In terms of severe adverse events, there were very little or very few to be reported. And most of the discontinuation could have been, some of the discontinuation could have been due to hyperkalemia. And this particular outcome was left at the discretion of the investigator. So there was a little bit of inconsistency there. So when you look at these trials, one way of examining them is to look at the population of the trials. Of all the 5 trials that looked at diabetic kidney disease in people with type 2 diabetes. So we have the Credence that looked at canagliflozin, DAPA is dapagliflozin, CKD, EMPA, kidney, Fidelio is finerenone, and FLOW is semaglutide. And well, the 2 DAPA and EMPA kidneys included as patients who don't have diabetes, but the other 3 100% had type 2 diabetes. Their Credence and Fidelio had a high rate of people with pre-established cardiovascular disease, about 50% almost. The eGFR at enrollment was 25 to 75, and that sets the scene of when can we start these medication, the lower eGFR that we can start with. There was some differences between the other trials. Majority Credence and Fidelio looked at macroalbuminuria, and the DAPA, CKD, and FLOW included a mixed bag of micro and macroalbuminuria. However, empagliflozin, EMPA kidney study looked at a myriad of patients. The longer duration was seen by the FLOW with the FLOW trial, and the others had about 2 to 2.5 years follow-up. If you look at the population cohort here, you'll find that the highest risk group actually was enrolled in both of the Credence and the Fidelio, and they're pretty much similar in terms of the composition of the population being enrolled. EMPA kidney, from my point of view, had the lower risk group, and it pretty much represents a group of patients who might attend the general renal clinic. So when you look at the outcomes in these studies, you'll find that number needed to treat are pretty much similar across all groups. The eGFR slope was had a lower decline with the Credence, followed by the Fidelio, followed by the FLOW. But again, these are the highest risk cohorts. The 3-point MACE was reduced in both the SGLT2 inhibitors, Credence, and also reduced in the Fidelio groups, but was not tested in the other groups. So you have a myriad or a group of medications that's all tested to be positive. The differences between them could be explained by the population, but also could be explained by the molecule itself. And the interesting part, which later on Professor Malik is going to look at, of about how if we combine 2 of these agents together, what are we going to see? Another study that looked at finerenone is called the Figaro trial, another kind of an opera name. And in this trial, they actually looked at cardiovascular event rather than kidney disease. So pretty much similar inclusion criteria, but the outcomes are flip-flop. So the primary outcome is 4-point MACE. The secondary outcome is end-stage renal disease, and pretty much similar population being enrolled in the trial, similar in almost all aspects. And the Fidelio was particularly, there is an overlap between the 2, but that particularly these groups with a high risk of cardiovascular disease. Now, they did exactly the same hierarchical analysis, but this time starting with the 4-point MACE, moving to renal disease, and then moving across to the different forms of outcomes. And once they hit an outcome that's not significant, they stop. And what this study showed is that the primary composite outcome, which is the 4-point MACE, was actually reduced in this trial. However, the rest of the findings, the next step was not significant, and then we stopped here at this point in time doing any more analysis. An interesting or another analysis that pre-planned analysis was known as the fidelity analysis, because as I showed you, the Figaro and the other study, the kidney study and the renal study, both of them included similar group of patients, and they used the same medication, finerenone, 10 to 20 milligrams in the study. So it makes sense to pull them together in one analysis. And the pulling them together actually confirmed that there is a 14% reduction in the 4-point MACE. Seems to be mostly driven by reduction in heart failure, which will become a focus maybe in the future. And in terms of kidney disease, they added an extra outcome, which is more than 57% EGFR increase in the reduction by more than EGFR, by 57%. And if you zoom into this a little bit more, you will find and appreciate that all outcomes, individual outcomes, apart from the composite outcomes, all individual outcomes seems to be significantly reduced in the with Fineron compared to placebo arms. So where does this leave us here? So currently the guidelines recommend the first line to be SGLT2 inhibitors still and metformin, but the non-steroidal mineralocorticoid receptor, which the only agent here is Fineron, is recommended as a second line if the albuminuria persisted despite or there is a contraindication to use the first line. And the recommendations are you can start it as long as the potassium is less than 4.8. If the potassium is gone above between 4.9 to 5.5, you might need to continue, but to monitor. But once it increases 5.5, you might need to stop. Like we used to do with ACE and ARBs in the past, you just hold them till the potassium comes down and then reconsider restarting it again at a smaller doses. And they have been licensed and recommended in the ADA to be used for prevention of progression of kidney disease and for prevention of cardiovascular disease in people with established cardiovascular disease based on the Fidelio, Figaro, and Fidelity. So I'm going to stop here and I'm going to wrap up by echoing what my colleague and friend Dr. Targil has said, that diabetic kidney disease prevalence and incidence are on the rise. And I just want to stress what he stressed early on, that early detection and appropriate management are critical. I've already shown you that there are disease-modifying agents that are currently available and that they do change the course of the disease. And I hope I've shown you that Fineron, which is the only non-steroidal mineralocorticoid receptor, which is different from the others, reduces both diabetic kidney disease progression and cardiovascular disease in people with diabetic kidney disease. It is very well tolerated with a low incidence of hypokalemia, hypotension, and pretty much has no anti-androgenic effects. With this, I would like to stop and thank you and pass over back to Dr. Bashar. Thank you very much.
Thank you. Thank you very much. Excellent presentation. Again, we will get to the questions after the last presentation. So please, if you have any question, put in the queue and answer box, and we will get back with all answers to all questions. Now, before I move to the third presentation, I would remind you to register for the endocrine review. This is now a tradition of the Gulf Association of Endocrinology and Diabetes. So if you're interested, if you have to take any examinations, we advise you to take this endocrine review course, and this will be done virtually this year between the 6th and 8th of November. So please register or get a sponsor to support you as well. Now it's my great pleasure to move to the third presentation, and it will be about the clinical implications of early management with Finerenone. And this will be presented by my dear friend Riaz Malik. Professor Riaz is Professor of Medicine at Weill Cornell Medicine in Qatar and University of Manchester. Professor Riaz, it's a great pleasure to have you. The floor is yours.
Assalamu alaikum. Thank you, Bashar. Just waiting for them to allow me to share my slides. Right. So I'm not sure what else I can add to tonight's discussion on renal disease, and because what we've learned so far is renal disease is bad for you, and Finerenone works very well. And if we look at clinical guidelines now, actually, no matter which guideline you look at, whether it's the American Diabetes Association, European Society of Hypertension, ESC, they recommend, not just in the good old days where it was RAS inhibition for renal disease, but actually SGLT2 inhibitors, GLP-1 receptor agonists, and most recently, the non-steroidal mineralocorticoid receptor agonists, which obviously Mohammed talked about. Now, when you have 3 or 4 drugs, what happens is you end up actually saying, okay, I'm going to start with one, I'm going to wait a bit, then I'm going to add, then I'm going to wait a bit, and then I'm going to add. And of course, the waiting bit for glucose is, you look at the HbA1c. For kidney disease, is pretty much proteinuria, because we know that GFR will at best remain kind of, less, will progress less as opposed to if you don't treat. So what we tend to get is a traditional conservative approach, which is that you eventually get to where you want to in terms of maximal, or I would say optimal therapy over many months. So you'll start with an ACE or an ARB, you titrate that dose up 3 months, then you'll think about an SGLT2 inhibitor, and then you're adding that in, you'll wait another 6 months, then you'll reevaluate the albuminuria, and then eventually you might get onto non-steroidal mineralocorticoid receptor agonist, or probably even a GLP-1 receptor agonist, titrate that dose up, and eventually you'll get all 4 drug treatments. Now, there is also an accelerated approach, which is actually a little bit quicker, more rapid, ACE or ARB, SGLT2 inhibitor, non-steroidal mineralocorticoid receptor agonist, GLP-1 receptor agonist, and you're basically titrating the dose, reinforcing adherence, and maximally controlling the risk factors. And there is now a rapid sequence approach, which is actually, ACE and ARBs obviously are always going to be there, but now you've got a choice between non-steroidal mineralocorticoid receptor, GLP-1 receptor agonist, or an SGLT2 inhibitor. And really, you shouldn't kind of phase through. You should get onto these drugs as quickly as you can within 3 months. Titrate the dose, reinforce adherence, and really sequence through based on the dominant clinical priorities, and match the intensity of treatment. So quicker, the better. Used to be said less is more, but no, more is more, especially in the world of kidney disease, because as Mohammed Bashir pointed out, the longer you allow the albuminuria to remain, the higher of the cardiovascular outcomes, and the greater the progression of renal disease. So then the next question you should ask is, conventional approach, which is one drug at a time, as opposed to immediate combination. Well, there are data to show that no matter what outcome you're looking at, whether it's a doubling of serum creatinine, end-stage kidney disease, heart failure, all-cause mortality, combination treatment is significantly better, from anywhere from 25 to 50% compared to a conventional treatment, which is where you're going to be waiting and adding single drugs. And again, if you're looking at the benefit in terms of event-free survival, which is basically whatever event you might be, whether it's end-stage kidney disease, heart failure, a doubling of serum creatinine, then conventional, you can see on the right panel, does much worse than combination in terms of keeping you event-free. So, and really, the younger you are, the faster you get onto this, the better it is. And there is also now actually really interesting cross-trial analysis looking at all the big endpoints, so whether it's MACE, heart failure, or cardiovascular death. If you look at individual drugs on their own, and you'll see there's a benefit, clearly, compared to conventional care. But SGLT2 inhibitors, you'll achieve, say, 17% reduction. GLP-1 receptor agonist, 14% reduction in MACE and heart failure. But as you can see, as you progress with increasing numbers of agents being used, that is a GLP-1 receptor with a non-steroidal mineralocorticoid receptor agonist, you'll get better response. SGLT2 GLP-1, better response. SGLT2 with non-steroidal mineralocorticoid receptor agonist, which is what I'm going to talk about today in the trial, confidence trial, again, you see you get a much better response. And of course, combining all three, you get the best response. And that's true for MACE, cardiovascular death, and hospitalization for heart failure. And CKD progression. Again, you can see that the double combination has the better outcomes compared to single drugs, and to triple combination actually has the best outcome. All-cause mortality, again, similarly, you get better outcomes the more drugs you have, particularly the triple therapy. So, what am I going to talk about? The focus really is on early treatment, but early, not single therapy, but and maximal titration, but getting on and really combining drugs together. And the particular combination that the confidence trial assessed is actually the effects of finerenone on its own, empagliflozin on its own, or an immediate combination of both empagliflozin and finerenone. So this was a trial of, it was a randomized, double-blind, double-dummy, multi-center, 3-armed, parallel group phase 2 study. And you might kind of think, well, why is this a phase 2 if it's got drugs that are already on the market? You know, finerenone is, empagliflozin is. Well, actually, it's the approval. So whilst finerenone is approved for the outcomes that we're interested in, at that point, empagliflozin was not approved when the trial was started. So that's why they had to have a phase 2. And the other key thing is that patients were treated for 180 days, and then there was a washout period for 30 days to see what happens to all the outcomes. So, key inclusion criteria: age more than 18 years, eGFR between 30 to 90, proteinuria, good or well-controlled HbA1c of less than 11%, but I show you that actually they were really well controlled. So glucose was not playing a role here. And then also already on ACE or ARB. And the primary endpoint was a relative change in urine albumin-creatinine ratio from the baseline to day 180, assessing whether the combination approach was, how did it fare against empagliflozin alone or combination against finerenone. Secondary outcomes were all around efficacy, actually looking at what happens when you at the end of treatment, end of 30 days, and also between the 30 days and after end of treatment. And then the secondary other outcomes were safety outcomes in terms of eGFR, acute kidney injury, and hyperkalemia. So, for the confidence trial, there's actually a diverse range of patients with chronic kidney disease and type 2 diabetes. Mean age was 66, BMI was 29, mean eGFR was 54, and they definitely had proteinuria. HbA1c, as you can see, however, was really well controlled, 7.3%, and potassium, because of the inclusion of requiring a potassium to be less than, a certain amount, and we'll go into that, was 4.5. But as you can see, they had hypertension, atherosclerotic cardiovascular disease, diabetic retinopathy, and virtually all of them were on ACE or an ARB, and about a quarter were on a GLP-1 receptor agonist. Key efficacy and safety data, well, as you know, the primary endpoint was the reduction in urine albumin-creatinine ratio. So, does simultaneous initiation of finerenone with empagliflozin do better than either alone? Yes. So there was a greater reduction in UACR at day 180 with the combination compared to Corandia or finerenone alone by 29%. And when you compare it to empagliflozin alone, this was 32%. Furthermore, the absolute reduction in urine albumin-creatinine ratio combination therapy was actually achieved in 30% at day 30 and up to 52% at day 180. Then if you look at the safety, pretty low in terms of adverse events, and discontinuation was very low across all treatment groups. There was, as you would expect, an initial drop in EGFR, and you'd expect that with either an SGLT2 inhibitor and also with finerenone, but no serious adverse events that led to acute kidney failure. There was also a drop in systolic blood pressure. I remember Mohammed Bashir actually said that there's not much of a drop, but in this case, actually, there is a drop, and we'll talk about that. But the incidence of symptomatic hypertension was relatively low. And of course, potassium, which is important, hyperkalemia rates numerically low, and for what it's worth, the combination, that is the finerenone with SGLT2, with the empagliflozin, was actually lower than the finerenone alone. Again, actually, to me, arguing for getting on and just combining both if you're worried about the potassium as opposed to waiting. So overall, these data seem to, well, they hit the primary and suggest safety. So if we look at the data itself, what you see here are in the top, the red and the purple represent the effects of empagliflozin and finerenone. You can see there is a drop in a urine albumin-creatinine ratio in both those therapies, but clearly much more in the combination arm, and very quickly, within 14 days and definitely at 30 days, it's a much lower urine albumin-creatinine ratio. This is maintained and actually maybe gets a little bit better even in the early days up to 90 days. And then actually when you stop the therapy, you can see in all the arms, it goes back up. So you really clearly need to be on treatment. If you look at the study again, overall, 52% reduction in urine albumin-creatinine ratio, clearly better than the 32% achieved in the finerenone arm alone and the 29% in the empagliflozin arm. But again, you can see that this reduction in urine albumin-creatinine ratio, it goes back up, maybe a little bit less than baseline, but nevertheless goes up after 30 days. If you look at the EGFR, now here you see that with the finerenone, there is a reduction in EGFR alone. And of course, with the SGLT2 inhibitor, there's quite a big drop initially by about 4. But then the combination is 6, and this is maintained. But the most important thing is that this is reversible, this is hemodynamic, because you can see that actually with the combination arm, it really shoots back up to almost the same as when it was where it was when it started. So, and the incidence of acute kidney injury and the combination therapy was no different to the drugs alone. So, what about, blood pressure? Well, again, blood pressure actually, systolic blood pressure, did drop by almost 6 millimeters of mercury in the combination compared to 4 and say 3 in the empagliflozin and finerenone arms. But again, the blood pressure, as you can see, remained low to 180 days, but when you stop it, it comes back up to normal. Potassium, any hyperkalemia emergent events, you can see actually that the empagliflozin arm, the lowest, then next up was the finerenone arm, but was actually slightly lower in the combination. And then discontinuation rates due to hyperkalemia were very low across all groups. You can see virtually non-existent. So there was clearly hyperkalemia, but not a huge amount, and in fact was better when the combination, and there were no cases that led to hospitalization or death. So overall, my takeaway message would be that simultaneous as opposed to individual initiation of finerenone with empagliflozin led to an early and clinically meaningful reduction in albumin excretion, which was maintained out to 180 days to 52%. But remember, after 30 days, it was actually already 30%. And it was well tolerated in patients with established CKD with an EGFR around 50 and proteinuria, but an overall good HbA1c. So in terms of practical matters, If the serum potassium is less than 5, if it's more than 5, you shouldn't start it. But if it's less than 5, 10 milligrams. If the EGFR is less than 60, 10 milligrams. Is greater than 60, you can start with target, and maximum recommended dose is 20 milligrams. If the EGFR is less than 25, you shouldn't start it. Thank you.
Excellent. Thank you very much. Excellent. So now, please, if you have any questions, just put it in the Q&A box, and we will start taking questions from the audience. Great presentations. Dr. Tariq, Dr. Muhammad, and Dr. Riaz, please join me for this session. And actually, we started. We have many questions, and I will give it not in any order. And please feel free, 3 of you, to comment on this, because it might enter between the 3 talks. So this is the first question. In patients with diabetes who are taking SGLT2 inhibitors, which are known to increase the risk of urinary tract infections, what is the best way to accurately assess proteinuria?
It should be at the time where we. It should be at the time where we don't have any clinical symptoms or suggestion of proteinuria. We didn't discuss proteinuria in a little bit more details because proteinuria is not tested only once. So you need to have a persistent proteinuria tested at different times. The false positive rate of proteinuria, which is the albumin-creatinine ratio that we measure, is actually quite high. And with lack of standardized assays, you cannot depend on one reading. So you want to make sure that the patient doesn't have symptoms of UTI. And number 2, you need to make sure that whatever finding you have is actually confirmed in another test, which we usually recommended to wait for about 3 months to repeat it again before you take you take the readings or actually report that the person has proteinuria.
Another question for you, Dr. Muhammad. Now, how do you differentiate between CKD and DKD? Now we hear both of them. Is there? I mean, is it the same? Is it different? What is the difference?
CKD is chronic kidney disease. DKD is just the new name for diabetic kidney disease. It just moves from diabetic nephropathy because the term diabetic nephropathy belongs to when it brings in mind the idea that there has to be proteinuria before you diagnose diabetic nephropathy. And what Dr. Tariq just clearly showed up that right now, a good 30 to 40% of people who have kidney disease based on the reduced EGFR don't have albuminuria. So that's why the term has changed from diabetic nephropathy to diabetic kidney disease.
Very good. Exactly. And yes. I think the other part of the question, before I go to that, just to add to the issue you have just alluded to regarding the proteinuria versus non-proteinuria. And as I mentioned, classically, 2 decades ago or more, there has been a sort of a conventional understanding that no proteinuria means there are other causes for the kidney dysfunction. And in these circumstances, I remember the nephrologists tend to go straight away for renal biopsy. Okay, so now the phenotype actually is overlapping. And as I have shown in that slide, it might actually coexist in the same patient. And the hallmark of the non-proteinuric phenotype is that it does actually feature more in women and more in patients with actually metabolic syndrome. So those are the 2 things which you have to bear in mind when you consider the two sub-entities. Regarding the question of the the delegates regarding the infection, okay? The infection, we don't see it actually much with the SGLT2 inhibitor in our population, at least in Qatar. And I assume the population more or less actually are carbon copy, in various Gulf countries. However, you should remember that the risk of mycotic infection tend to be high in women, and those with very high HbA1c, when you start the SGLT2 inhibitor. And the other thing is that, it does feature actually in non-circumcised actually males, which, usually, most of our population, apart from non-Muslim population, are actually circumcised. Thank you.
Okay. This next question is for the panel. Do we have any validated risk calculator for CRM? Do we have any calculator that we could use to make the diagnosis or to know that our patient is a higher risk for that? Is there anything like that or not?
Okay. So the way the KDIGO kind of heated map, all right. So if you put the person in the KDIGO heated map and you check the EGFR and the albumin-creatinine ratio and you see where the patient fits exactly, it tells you where, based on the color, what are the risks of this person progressing, or what is the risks of end-stage renal disease. And that's why it's very important to plot two of them at the same time. And also it can tell you how frequently you need to monitor it. So if somebody on the green boxes, you only need to do albumin-creatinine ratio and EGFR once. If they're in yellow, you need to do it twice a year, and so on and so forth. Having said that, there are risk calculators for end-stage kidney disease. If I remember very well, there is a British risk calculator for end-stage kidney disease, which I'm pretty much sure exists. That includes various data that tells you what is the risk of this person progressing to chronic kidney disease over the next 5 or 10 years. The Steno 2 calculator. Steno is a calculator that looking at the risks of type 2 diabetes, for type 1 diabetes, risk of cardiovascular disease, but it also reports on the risk of kidney disease. So if you go to the Steno website, and you use the Steno engine and you log in all the details, it will give you a simultaneous results for kidney disease and for cardiovascular disease. I just don't remember the British one, but there is definitely a British one. Maybe Riaz, if you can remember it, but I'm sure there is one for kidney disease, a calculator for it.
Another question from the audience now. Since we don't have finerenone in our many hospitals and practices and even countries, can we use aldactone as an alternative in patients with diabetic kidney disease? We say they do almost the same.
Yeah, Bashar, I'll answer to that.
Use it as an alternative?
Yeah, so there are actually very old data in both type 1 diabetes and type 2 diabetes that do show spironolactone reduces proteinuria by about 30%. Clearly, we have issues with the side effects of spironolactone, but I must say it's a very effective blood pressure lowering drug. When you've got patients on ASARBs and nothing's working, you put a little bit of spironolactone, 25 milligrams, and their blood pressure drops. And there is definitely data from actually the Steno that showed benefit on proteinuria.
Yes, clear. Now, another question. ACR. Yes.
I just looked it up. The equation called the kidney failure risk equation. It's a British website risk calculator they can use if you want to calculate it.
Okay, very good. Now, can we use GLP-1 in DKD with history of before pancreatitis? History of pancreatitis, can we reuse or use or? No. 3 of you are saying no. Okay.
I have a different take a little bit here. So I think if the just being overweight. So if you have a reason for the pancreatitis, like a gallstone, and that's one. Number two, the patient has this. For me, something happened a couple of decades ago or a decade ago. I probably give it a go. If there is a reason for it. But generally speaking, if there is a other cause of pancreatitis, you probably won't give it.
Yes, back again, Bashar, if I may, regarding the availability of finerenone. It is now available in Qatar across the board for all sector of patients, Qataris, non-Qataris, and this has just been sanctioned actually. So it is available. I'm not sure about UAE and other countries.
Now I'm being asked here if the ACR is fluctuating around 30, once above and once below, what should you do? Would you, add or just monitor? I'm not sure. What's the point of this one? If the ACR is fluctuating, would you treat or would you just monitor for persistently elevated ACR?
I think you have to treat, because you don't need anything else. What else do you need? Because as long as it is there, the risk of progression is there. So you have to treat. This is my personal stand. And
yeah. Any other opinion on this?
I think the numbers, as I said, the fluctuation was expected. So you don't expect to do two samples even in same day with different assays to get the same results. So you will get a fluctuation. The point is, where is the range? Where are we in terms of the range? In what category are we? And as I said, you usually don't depend on only one reading. So if somebody has a macroalbuminuria, well, if it was 35 milligrams per millimole and then became 50 and then came down to 30, this person has macroalbuminuria, need to be treated. And person don't need to be put on the appropriate therapy.
Great. Dr. Riyad, now if the cost is the issue, in a case chronic kidney disease, type 2 diabetes, stage 3 CKD, how would you treat? And hypertension, how would you treat? What would you choose first? Cost is very important for the patient. So please guide us, which one of the 5 pillars you use, in real life practice?
ASAP, because they're all off patent, so they're cheap. And probably made by companies in India or whatever, so they're going to be even cheaper. Next would be an SGLT2, because that's cheap. I honestly, finerenone, I don't know what the cost is, but that would be my number 3, and then GLP-1, the most expensive. That would be my order. And if you can't afford or you don't have available finerenone, then spironolactone.
Yeah. Now, how about type 1 patients? We heard about type 2, and type 2. Whatever we heard, does it apply to type 1 also? CKM and all of that, does it apply to type 1 patients? Dr. Muhammad?
So here is the question that requires a lot of speculation. So type 1 diabetes have the same problems, and the end result of most chronic kidney disease seems to be the same. So the benefit of SGLT2 inhibitors, for example, were seen in people with or without diabetes. So I have to say, the worry about SGLT2 inhibitors in type 1 diabetes are all linked to the risk of DKA. And as time goes on, we will have to face the reality that we need to learn how to mitigate the risk of DKA in those type of in type 1 diabetes. However, from my point of view, finerenone provides a good opportunity to be tested in people with type 1 diabetes, because it doesn't have the side effects or the adverse events that people are worried about, which is diabetic ketoacidosis, which I think with proper education could be reduced significantly or avoided in most patients. So finerenone does provide a hope. Technically, when you read about the technicality of the guidelines, they don't say don't give the patient. They say offer those medications to people with chronic kidney disease. That's when you look at chronic kidney disease patients, but they specifically does not exclude type 1 diabetes. So we're facing the reality that we have to do something, and I think finerenone for me will be the first choice till we have a little bit more solid data on even the dose of SGLT2 inhibitors. So now looking at smaller doses, EMPA 5 milligrams, EMPA 5 and EMPA 2.5 milligrams, which seems to be quite effective in type 1 diabetes and safe.
Now, the next question here is, what's the best management for patient need operation? And he has CKD, type 2 diabetes, and history of cardiovascular disease. I don't know what's, this question. Is there any sick day, rules for using finerenone like SGL2 post-operation or so?
Don't know.
I'm not sure if the question is asking about what will we do if somebody taking the medication and going for an operation. We know if somebody is taking SGL2 inhibitors and get admitted to the hospital for pretty much any reason that we hold it during the hospital stay, including people going for operations. Question is, should we hold the finerenone when somebody gets admitted to the hospital? And I'm sure with experience people will come to an answer. However, if there is a worry about hyperkalemia, particularly, then probably yes, you probably might need to help to hold it. If you're worried about hyperkalemia, or hyperkalemia is the reason for the admission. But I think with more experience, we'll be able to know when or if we need to stop finerenone on people admitted to the hospital. But SGL2 inhibitors, definitely yes.
Do we have any data quantifying the renal protection between all of these agents, ARB, ACE, SGL2 inhibitors, finerenone? Do you have any data to compare the outcomes with these agents?
I presented it, Bashar. There's like cross-trial analysis. There's no head-to-head, but there is cross-trial analysis, which shows you that individually all of these drugs probably achieve similar amounts of protection. And then, the more combination you get, or you have 2 drugs, it's better. 3 drugs, it's even better.
ACE and ARBs don't seem to reduce. ACE and ARBs seems to reduce albuminuria significantly, and that probably the wide use of ACE and ARBs are the reason why we have non-albuminuric diabetic kidney disease. But they don't seem to significantly reduce the progression to diabetic kidney disease. So they are there at the background, and I think they will continue to be there unless somebody very courageous decide to do a trial without them and see if there will if we don't need them in the future in kidney disease. But they don't seem to impact the progression to chronic kidney disease. And as Dr. Riyad said, I also presented in my slide, the differences between the trials, you need to look at the population because the population were different, the inclusion criteria was a little bit different, and the definition of outcomes were a little bit different. So it's hard to compare between these trials. However, for me, as I saw, the credence and the finerenone had the highest rates of high-risk population, and the results were pretty much similar. I was hoping that the studies will last a little bit longer because you can see it takes a bit of a time for the initial insult on the EGFR to plateau. So I think if we continued a little bit longer, we might have a better understanding of the longer-term impact on EGFR.
Now, we have many questions on hyperkalemia. When would you definitely stop the treatment? At what level? Dr. Riyaz, at what level you will stop the treatment?
I think there is a
hyperkalemia. What level you will decide to stop treatment?
I think there is a kind of a advice and 5, was it 5 or 5?
5.5.
5.5.
5.5 millimoles per liter, yes.
Now, are there any tricks that you could do to continue giving the treatment? Potassium binder or anything? Are there any tricks that you could do, or you should stop treatment?
I think you have to look at the profile of the patient. Some patients might have extra risk, there might be some other reasons. You can take history, see concomitant medications, and repeat the test. Ask about whether the sample has been repeat the test, because sometimes patients might go to the primary healthcare center, they will have their blood test in the morning, and the sample will be sitting there and shipped to the hospital late in the afternoon. So you might get a spurious hyperkalemia. So I think before you consider stopping, any drug that cause hyperkalemia, you just have to look into the circumstances surrounding spurious.
Would you re-challenge after you stop the treatment? Would you re-challenge again?
Definitely.
So what's written in KDIGO is hold it, So I think it's exactly the same approach for ASNRs. So ASNRs can cause hyperkalemia, and what we used to do is we hold it, make sure the potassium comes down, it starts with a lower dose, and we monitor more frequently. So exactly the same here. So we hold the medication, potassium comes back to normal, then you can restart at a smaller dose and just recheck it again. However, having talked to our colleagues in nephrology, they seems to use a kind of chelating agent in order to reduce the hyperkalemia if it came back again, if the hyperkalemia recurred.
This is from a nephrology colleague now.
From a
How about
colleague,
How about the use of finerenone in CKD patients due to glomerulonephritis, not diabetes? Anyone has any experience with that, or no hypertension, no diabetes? Does it have the same benefits? Anyone has any experience with that?
I think unless there is a nephrologist on the panel, I don't think so.
They're asking, actually.
They're asking. No, there's no nephrologist in the panel.
No. I have a long list here, but some of the questions. How about the use of finerenone in resistant hypertension? Do we have any indication for that at this time or not yet?
I can tell you spironolactone works really well. So I would have a guess to say that finerenone probably will have some impact as well, but I don't think there's been any studies.
Okay.
We're talking about finerenone in primary aldosteronism. Is that the question?
Yeah, one of the, secondary cause of hypertension. Yes. Is there any data on?
I don't think it's been tested. So what seems to be happening is that Riyadh, the data I've shown from the Figaro and Fidelio, the impact on blood pressure was quite low. However, the data Riyadh showed from the confidence that has a reduction of about, is it 4 millimeters mercury, Riyadh? I think in your study. And I'm not sure if they started at different baseline or not. So the impact on blood pressure seemed to be low. However, I don't think it got tested. It seems will it have any impact on primary aldosteronism or not? And this type of studies might not attract a lot of interest from the companies to fund right now, because it's quite rare to have these type of endocrine disorders. But from the mechanism you have seen, the way it impacts the receptors, it seems to have a promising potential, to be honest.
So I've actually just looked up the potential other effects in other kidney diseases, and there is some evidence in the clinical trials for IgA nephropathy, and there are ongoing trials for other glomerulonephritides at the moment with finerenone.
Okay. Now, any experience with the use of finerenone during Ramadan fasting, during Ramadan? Dr. Tariq, do you have any experience? Did you come across any study done by Dr. Effendi?
We have just got the agent actually approved in Qatar. So we will definitely have experience in the near future in many spheres.
Yeah, actually, we had a small study that showed worsening and increased risk of probably hypoglycemia. However, it's a small study, and the baseline groups were not similar. So, worse and more insulin and so on. So probably it was related to many other factors, not the treatment itself. We are working on a bigger study at Tawam Hospital now doing that. Now, let me see what else we have here. Do you believe, three of you, do you believe that this medication should be restricted to subspecialties, or it could be used by anyone?
It's a safer spironolactone. So I don't see what the issue is.
I can't agree more. Why should it be restricted? Because it does overlap cardiology, nephrology, diabetes, renal medicine.
Yeah, makes sense for everyone to have it. Now, another question, do we have any markers that you could estimate that this patient might benefit from the treatment or not? any markers that makes it make sense to give this patient, not that patient, or so on, maybe BMP or troponins or anything else? I mean, nothing at this time, right?
Well, you have albuminuria as a marker to give it. Reducing eGFR is a marker to give it.
But I'm talking about patients who would respond or not respond to treatment, no markers to estimate that.
That applies to almost every other medication. It's not only Finerenone. So some people don't respond to SGLT2 inhibitors. Some people will, GLP-1 receptor will not even touch them. So there's probably a reason for that, but it's not being teased off in many of the medications we use.
Right. Now, another question on patients with prediabetes. Can patients with prediabetes have a high ACR?
Yes.
Of course.
Yes. Of course. This is from Dr. Riaz. Yes. Clearly. And would you treat with Finerenone?
Yes.
Beyond doubt. Why not?
Okay. Okay. So is it approved in prediabetes? No hypertension?
No, I don't. It's not approved for it.
Well,
I'm not sure that it's not probably.
No, because the trials are only done in
But I
type 2.
think, yeah, I think you can justify it by inference because such patients do have high propensity for cardiovascular disease, and some of them could well have established microvascular disease. So even in the absence of, the license, there is nothing to bar you from using it actually on sort of ethical grounds.
Right. Did you come across any data that GLP-1s increase proteinuria even on maximal dose of ARBs or ACE inhibitors? GLPs cause
the converse
increase or reduce?
increase the question.
It is the other way around.
It might be additional, yeah. So the answer is no, it actually does reduce. There was some data on liraglutide, right?
And
liraglutide, dulaglutide, and semaglutide.
Yeah, the flow study shows definite impact on reduced rate of GFR loss and protein and actually hard kidney endpoints.
Absolutely.
How soon would you correct potassium if you stop Finerenone? If there is hyperkalemia, how many days the Finerenone will last?
You need hands-on on that in order to answer the question. So I said, as time goes on, we will learn about it. What you used to do with AS and ARBs, you will hold them for a week and then you recheck and then restart it again. But again, it depends on how high is it. So if your potassium is 6, you'll be admitting the patient to the hospital, bring it back down normal immediately. If it is a little bit higher, you will hold it and monitor them as an outpatient. I think the half-life of Finerenone is about 2 to 4 hours. So it will take a couple of days or maybe less than that to get out of the system.
Now, a question here on the management of diabesity. Any suggestion on the approach of that? I mean, it's not probably similar to the CKD, risk patients. Any specific, recommendations on your side? The question I get a few times here, would you treat diabesity any differently in patients who have DKD? Or it follows the same guidelines here?
Diabetes is just a fancy name putting diabetes and obesity in the same category. I don't think it's adding much about from it sounds nice to have this diabetes, but
are these patients are at higher risk?
And they're same high risk as I showed in the graph early on. It's the chronic kidney disease process seems to start early on with the ectopic fat deposition, whether people are obese or not, and there is a category which is known as now being described and discussed as fatty kidney disease. So approach will be pretty much the same. You need to do exactly the same as you do if somebody has diabetes. Bring the weight down, control the lipids, control the blood pressure, and treat the kidney disease in the similar way.
I think we we finished here. We still have a few questions, but probably we covered most of them. So I like to really, at the end of this session, to thank our speakers, three of you, excellent talks and interaction, Professor Riaz, Professor Tariq, and Professor Muhammad. Thank you very much for your
Shukran, Bashar.
Thank you very much.
Thank you, Rafat and team. And thank you, Bayer.
I'm not closing yet. Yes, I want to remind all the audience, please, if you want to get your CME, you need to complete your evaluation. Also, remind you here to, join us next month for the GATE annual Congress. Try to get a sponsor. I know that Novo is interested in supporting all of you. Just send a letter to Novo, ask the rep from Novo to support you. Hopefully, we will get you join us. Also, I wanted to remind you to come to become a member of GATE. Also, for those endocrinologists who are interested to take the endocrine board review, please. Here's the date for that, 6 to 8 November. So please, if you're interested, if you have your exams, please register for that. Again, by the end, submit your evaluation to get your CME. And by the end, I like to thank the audience, 600 audience, excellent presentations. I like to thank Bayer for support. And please, follow us on these platforms. And thank you very much. Thank you. Assalamu alaikum. Thank you very much, all of you.
Assalamu alaikum. Have a good night.
Thank you. Thank you for wonderful moderation. Thank you.